Hi everyone, my name is Valerie Inahosa, and today we'll be doing a presentation on a hearing screen via the Pure Tone Audiometer. So this screening tool is used to detect unilateral and mild hearing loss in children. It measures both air conduction or bone conduction. As you can see, one of the pictures illustrates a girl wearing headphones. That's the one that measures air conduction, and the other one is measuring bone conduction. It measures hearing in decibels at varying frequencies. 20 decibels is about as loud as a whisper, 40 decibels is normal speaking, and 90 produces pain. So who needs a pure tone audiometer screen? Any child above the age of 4 during a well child visit should have a screen done. And then there's several risk factors where screening should be done. These include if a child fails to respond to auditory stimuli, if they have delayed speech or speech that is monotone, or if they're difficult to understand, or if they're avoiding speaking in general. It's also meant for any child who has failed the screening test in school, who has been noted to misunderstand assignments, who are often confused or miss what is being said. It also is for kids who have shown aggression or have difficulty in school or in social situations. And then kids with environmental exposures such as loud noises like firecrackers, pistols, firearms, loud music, or machines such as snowmobiles, farm equipment, and lawnmowers. Lastly, it's also meant for any child with a history of a head or neck irradiation. So the age-related considerations, like I mentioned, it should be starting at the age of 4 with the well child visit, and then it should be done at the 5th, 6th, 8th, and 10-year-old well child visit. Adolescents should also have the screening at least 3 times in their adolescent history, and this is more so to detect any changes that might affect their language, academics, and social well-being. So the methods to complete the procedure. So the hearing is tested with both air and bone conduction, as I had mentioned previously. Air conduction is performed with the earphones. It tests the ability to hear when sound waves travel through their normal route through the external auditory canal to the tympanic membrane and the middle ear. The bone conduction test is performed with the oscillator placed on the mastoid bone, and that tests the ability to hear when the middle ear is bypassed and the inner ear fluid and cochlea are stimulated directly with bone vibration. And the child is basically asked to raise their hand whenever a sound is heard for the air conduction test. So the expected outcome and follow-up required. A normal passing score is a score below 20 decibels. Hearing loss that's considered mild is if it's passed between 20 to 40 decibels. Moderate hearing loss is considered 40 to 60 decibels, and severe hearing loss is considered 60 to 80, and greater than 80 is considered profound hearing loss. So if a child is found to be failing their hearing exam, then a referral needs to be made to an ENT. Children who have abnormal audiology results should refer to the ENT, a speech language pathologist, and early intervention. Delayed identification has been noted to result in delayed developmental and permanent deficits. It also impacts the sequential memory, abstract thinking, executive function. Children have been known to have poor academic performance, poor personal social maladjustment, and emotional difficulties. Billing and coding considerations. The billing code of 92552 is the code used for the pure tone audiometry, which is just air conduction only. If a child fails a hearing screening and needs a follow-up visit, then you can use the codes 99212 through the codes 99215. The ICD-10 code of Z01.118 should be used for the initial encounter of examination of the ears and hearing with abnormal findings. If there is an assessment that's done without any abnormal findings, then you can use the code of Z01.10. The ICD-10 code of Z01.118 should be used as an encounter for an ear exam with abnormal findings for a patient who is strictly coming in with complaints of ear pain or any issues related to the ear. This should not be used for a well child visit and you're doing an ear exam. Other considerations is the newborn hearing screenings for young patients, including patients who are nonverbal or have delays. There should be a different type of hearing assessment that's more unique and tailored for their needs. So, clinical practice guidelines that have been set forth by the AAP for hearing screening, there is actually this nice diagram that I pulled from one of the articles under the AAP, and it basically just goes through three different categories of hearing exams. If you see the first one, it talks about an evoked autoacoustic emission exam that can be done for all ages. And it's just a procedure where you put a small probe into a sensitive microphone, or a small probe containing a sensitive microphone is placed in the ear canal for stimulus delivery and response. This can be done for all ages. Then between birth to 6 months, you can do an AABR test, which basically is placement of electrodes on the child's head to detect auditory stimuli presented through earphones or probe. And then lastly is the pure tone audiometer, which you can start at the age of 4 all the way up to adolescence. And that's how I mentioned you use either the air conduction or bone conduction to perform the test and have the child raise their hand when the stimuli is heard. This is my list of references, and I hope you enjoy my PowerPoint. Thank you.